We're here to welcome the world's best cardiologist, doctor in the entire world. I booked him 2 years ago, and he had to send me a video to say, I'm sorry, he had to jet off, you know, when you're in this field, you're busy, and RFK came before me. Don't know why. But this time he went to RFK last week, wasn't it? So this time he made it. So a big hand for my good friend, Dr. Aseem Malhotra.
Thanks, guys. Cheers, Al. Thank you. It's great to be here. Nice little intimate, you know, don't get to have talks like this not often. It's usually several hundred or a few thousand. So this is nice. We have a bit of a chit chat. Very quickly about me, my background. So I've been qualified doctor 25 years. I subspecialized in interventional cardiology. So for most of my early career, I was operating keyhole heart surgery and do it blindfolded. Got a bit bored of it. Thought I'd do something more challenging, take on big pharma instead, like the whole system. But actually, to be honest with you, it was more that I was getting more and more frustrated that, you know, these patients coming in, some of them would die, of course, on the table, you know, they wouldn't make it, but I wanted to stop people having heart attacks in the first place rather than just be treating them. And, you know, I'm someone that comes from a background, you know, a sporting family. I played cricket and I could have played professionally. I was always into OCD about exercise. I'm sure all of you can relate to that. So I always had that bias towards lifestyle and being a foodie as well. So when I started looking at all the research, realizing, bloody hell, you can actually not just prevent heart attacks, but you can even potentially, I'll maybe allude to this a little bit in my talk, reverse heart disease. And people are not being told the full truth because, you know, you've got this huge industry that is literally tyrannical. I said it in the US Senate last week. They're controlling everything, you know, and they're even, I said it in the US Senate, I said that, you know, the system, the misinformation is so great that even the president probably doesn't know the true benefits and harms of the pills he's taking. You know, that's what we're dealing with. So anyway, my area of interest, special interest, has been around cholesterol and statins, partly because, you know, we were told in 1985, it was predicted when these Brown and Goldstein got Nobel Prize for discovering that the LDL receptor, so LDL, so-called bad cholesterol, that was defective in people who had very, very high levels of LDL, something called familial hyperlipidemia. Affects 1 in 250 people, okay? Those people, and I'll break that down for you as well because that's very interesting. If you take them as a complete group, they do get premature heart disease. They're 30 times more likely to die of heart disease or heart attack before they hit 60, for example, right? So they thought we've sorted it, okay? That is the cause of heart disease, and they predicted the eradication of heart disease by the early 2000s. Never happened. The question is why? So this is where I started my investigation. Okay, so I'll get into that in a second. So if you want to take a photo of this slide, for me, this is this is everything. If you understand this, it's a very simple, elegant framework of practicing medicine. I call it the evidence-based medicine triad is what it's called, and I'll explain it to you in a second. It could also be the real democracy triad, right? It could be, this is, you know, we can solve a lot of the world's problems with information just from thinking about this, right? So as a doctor, I want to improve my patient outcomes. What does that mean? It means managing risks, treating illness, and last but not least, relieving suffering, right? That's what we do as doctors. And suffering doesn't just mean, in my view, people who go through traumatic experiences. It can be, how do you optimize people as well? Like, how do you get them in the best state they can be mentally and physically and socially, right? Now, what are the 3 inputs to get the best patient outcomes? Your individual clinical experience as a doctor, as a practitioner, right? Your knowledge, what you learn, the best available evidence, okay? So that can be on anything, on a drug, right? What is the best evidence on the benefits and harms of this drug, on a surgical intervention, on a lifestyle, right? How do we, so you incorporate that, and last but not least, right? Taking into consideration individual patient preferences and values. We're all different. We've got different preferences, things that are more important to us than you know, in some areas than others. So, you know, that's what you know, Western democracy is predicated on that, right? It's individual, it's autonomy and all that kind of stuff. And I'll tell you why that's important for patient outcomes. If the patient doesn't like or want what you're advising them, they're not going to be compliant, right? And it's not going to work. So it should be in keeping with what the patient really wants, but you've got to give them all the information, right? And that's how, and for me, I love it. I don't think anything can better that. But this was what? It's been 30 odd years, 30 plus years since this was, but evidence-based medicine unfortunately has become hijacked, right? It's been hijacked by powerful commercial influences. And just to give you some, just to give you some context here, a guy who I call the Stephen Hawking of medicine is a guy called Professor John Ioannidis in the University of Stanford. He's the most published medical researcher in the world. He's a mathematical genius, got the gold medal in mathematics in Greece, then went over to Stanford. He's a whiz. And he was able to look at all the way research is conducted and look at how they design trials and drugs and everything else. And he concluded that most published research findings are false. This is 2006. This is the most cited medical journal paper ever. Obviously, didn't get in the news, right? But imagine that. Most medical research findings are false.
No.
Is that what's it called? In US they have PubMed. They call it peer-reviewed research.
Yeah,
Is
exactly.
that what that's referring?
Everything. Yeah. And the reason for that is. Yeah. And he gives different reasons for it in terms of the way the studies are designed. But one of the things that he says the greater the financial and other interests and prejudices in the scientific field, the less likely the research findings are to be true. So if you think basically the more lucrative, right? Because, so I'll get into that in a second. Sorry, I'm just trying to put this on there.
But doesn't that make it impossible to do the lower bubble in the previous slide?
Exactly. Right? So going back to that, think about it for a second. Going back to it. If you're not giving, right? If anything is wrong with one or many of these inputs, you're going to at best get suboptimal outcomes for the patient, and at worst you're going to do harm. Okay? And so that's context here. Now, just on that note, you're going to be thinking, hold on a minute, this is medical science. It's supposed to be closer to the truth, etc., etc. So let's just get this right. Medicine is not an exact science, right? Most people think it is. You do surveys in America and across the world, they think it is. It's not even close, right? It's not like physics or chemistry, it's an applied science. It's a science of human beings. It's constantly evolving. It's a social science. We are dynamic. We are not fixed. I have engineers that come to me and they come with all these different pathways and this and this. It's like, no, the body's not like a machine, We can change from day to day. We can even, you can change your hormones even from the way you think, right? So that is, we've got to, understand that there are limits. Listen, I'm not throwing the baby out of the bathwater. I think medicine has produced a lot of good things, but there's a huge area of uncertainty with a lot of what we do. But it also means that it's, that medical science is vulnerable to manipulation, right? By people who want to maybe sell you something, okay? Maybe with the best intentions, but that's when people don't get the full information. And okay, so this is you can look this up because I think this is a great paper to read. In 2017, he then wrote this paper, How to Survive the Medical Misinformation Mess. Okay? And he made the point that 20 to 50% of all healthcare activity in the United States, and they spend about $4 trillion on healthcare, right? 20 to 50%, up to half, brings no benefit to the patient, is wasteful or harmful. And what are the reasons? So these are the reasons. He says, most published research is not reliable, offers no benefit to patients, and is not useful to decision makers. Now, bloody hell, okay, that's a lot, so that's a big deal. So why does it still exist? Because your doctor doesn't, can I swear? Yeah. Your doctor doesn't fucking know it, right? Most healthcare professionals are not aware of this problem. They don't realize, because, okay, I went to medical school, went to a very good medical school. We're conditioned to, we got our textbooks. We're told that what's published in the Lancet or the BMJ or whatever else is like the biblical truth, okay? Yeah. And we accept it that this is the science, It was like Fauci said, trust the science when it came out with the whole COVID scam. Sorry, it's not a scam, but you know what I mean. Some people may call it a scam, but let's just say there was a lot of misinformation there. And when he said trust the science, I thought that's the most unscientific statement I've ever heard. Yeah. Okay? Right. And then doctors are not trained to critically evaluate evidence because we're kind of spoon-fed to, and listen, we're the people that did really well in school, we got A grades or whatever else, but what you're doing is you're learning information, you're treating that as a complete truth, and there's a lot of complex information there, okay? And then that's it, you then go and practice medicine. That's basically what happens. Not realizing the information you're learning is potential to change, okay, over time, so you've got to have humility, and not taught anything about the alternatives around lifestyle, right? That's the way we're conditioned to practice medicine. So they can't, so what's published in the literature, like Ioannidis can basically, because he's a genius, look at a paper and say, hold on, there's this bias, not sure if this needs to be replicated, we shouldn't take this as truth. We're not taught how to do that. It's not difficult to do it, but we're not taught in medical school how to critically evaluate published research. And then last but not least, and this is what's most important for all of us, our families, ourselves, friends, relatives, whatever, we're not then given accurate medical evidence and time of when we're making a decision about whether to take a drug, whether to go for an operation, etc., etc. Right, this always makes people laugh, and this is actually true, been proven to be true. The father of evidence-based medicine said half of what you learn in medical school will turn out to be either outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which half. So you have to learn on your own. Now, this doesn't happen. I mean, I've been doing this because I'm a curious mind and I want to help my patients, and I'm angry about what's going on in the world with patients suffering, etc., etc. So I've had to learn my own. But I think most doctors don't really do that on their own. And again, and also we weren't taught this at medical school. We weren't taught that half of what you're going to learn is going to be outdated, dead wrong within 5 years.
Say is wrong, mate.
Okay, now let's talk about cholesterol, right? We were here to talk about cholesterol. So now I've given you the big picture. It will help you at least understand where we've gone wrong with cholesterol and why we've gone wrong with it. So, if you look at the original studies on cholesterol, okay, if you want to identify a biomarker, I was talking about this with Mike earlier, that predicts disease, what you want is a measurement that tells you it's in an abnormal range, you're going to get basically get the disease, or you're in the normal range and you're not going to get the disease, okay? That's what you'd hope for, and that would be a very nice way of measuring a biomarker that can help you make a decision over what to do about it. Now, if you look at the original studies that drove all the cholesterol guidelines and the way we think about cholesterol, this came from what we call the Framingham Heart Study, started in the 1950s in America, went on for decades, looked at 5,000 people, followed them up, and all different risk factor and associations emerged from that. Diabetes as a risk factor for heart disease, blood pressure for risk factor for heart disease, and high cholesterol. What was very interesting is, okay, so if you look here, these are the people that developed heart disease according to their cholesterol levels, right? This is in milligrams per deciliter. I'll explain that in a second and translate it for you in millimoles, okay? These are the people that developed heart disease, and these are the people that didn't. There's a massive overlap in the middle. So what they've basically determined is unless your cholesterol is very, very, very high, over 300, 400, so we're talking about 8, 9 millimoles per litre, that would be a predictive of heart disease, or if it was very, very low. Now, most cholesterol is genetic. You can influence it, the molecules, quite a bit by diet, but 80% of it is genetic. So people with genetically low cholesterol didn't develop premature heart disease. Right? They tended to not develop heart disease. People with genetically very high cholesterol had premature heart disease. So the thinking was straight away, right, we've solved it. It must be that we lower cholesterol for everybody, we'll get less heart disease. That was one of the ways they thought about heart disease being eradicated. But this is very interesting now. LDL is a so-called bad cholesterol. When Framingham was reanalyzed by one of its own investigators, William Castelli in 1996, he basically found this. He said, unless your LDL are very high, above 300 or 7.8 millimoles, which, by the way, I don't think anybody here, I doubt anyone here has an LDL that high, it is basically useless as a predictive factor for heart disease. So on its independently, when you look at everything, independent risk factor is not there unless it's at least 7.8, which, by the way, is, that's going to be 99.9% of people are not going to have LDL levels that high. Right? So that was already known by the late 90s, but it wasn't well publicized. Already by that stage, the cat was out of the bag. We got a low cholesterol for everybody.
Wasn't a danger.
Exactly. It was there. When you looked at the data, you're like, hold on a minute, something's not right here. All right? And then, again, there was another study that was done that showed that what we call, and we use this in risk calculators, a total cholesterol and HDL ratio is more predictive. So that's total cholesterol divided by your good cholesterol, and you get a ratio, and the lower the ratio, the better. Okay, that was again a predictive factor. Now, what is causing heart disease? I'll come back to cholesterol in a minute. What actually is the driver? And this is not my opinion. This is irrefutable. No one has challenged me on this, okay? But it's not well known because there's no market for the message. The primary driver of heart disease is insulin resistance, okay? Then high blood pressure, all right? Then it was low HDL cholesterol, then body mass index, then LDL, but again, LDL in all comers, not when you correct for what we call triglycerides and HDL, which I'll come on to in a minute. But basically, they concluded in this study in 2011, they said if you saw insulin resistance out, you literally prevent 42% of heart attacks, okay? And then high blood pressure would be another, 36%, etc. But this is the conclusion. Insulin resistance is likely the most important single cause of heart disease. A better understanding of its pathogenesis as in its cause and how it might be prevented or cured could have a profound effect. So they're saying, we know it's insulin resistance, but we don't know what to do about it, right? What sorts out insulin resistance? Low carb diets, stress reduction, we'll come on to that, okay? So again, it's there. No one's refuting this, but again, no market for the message, no drug.
No money in it.
No money in it, exactly. Now, this is going to muddy the waters even further, which makes it even more interesting, right? So one of the things that was determined from Framingham is, and again, wasn't publicized, when people hit 50, as their LDL cholesterol dropped, okay, the death rates went up. So myself and a number of other scientists decided to look at the totality of evidence up to date. Was there something different in the older population? So over 60s, which is when most people have heart attacks, was there an association with LDL cholesterol and heart disease? This is really interesting. We found, one, there was no association, or we kind of knew that already, but we just confirmed it. If the LDL cholesterol was not associated with heart disease if you're over 60. But this is even more interesting. We found, statistically, the higher your LDL, the longer you lived. Now, what's the reasoning for that? The reason is probably two potential mechanisms. LDL cholesterol is involved in the immune system. Older people are more likely to die from cancer and from fatal infections. So we think that is probably the mechanism of how it can protect you and give you a longer life. All right. So that's. So I remember published when we published this, I got it into the news, and I wrote an article in the Telegraph as well at the same time. I think this is 2016. I can't remember the date now. 2015, 2016. And I wrote this article, and I talked about this lady. I was in the clinic in hospital, and this lady got referred in by a GP, and she walked into the room, and she was white as a ghost. She was in her early 60s, and she came in, and she looked really scared. I said, "What's wrong?" She goes, "My doctor's told me my cholesterol's high." I said, "Oh, you're probably going to live longer." Right? And she was like, "What?" So we sat down and I explained it all to her, and she left the room a very happy lady, and she did not need to be on a statin. And I wrote about it, so you can look at it in Telegraph, it was great. Okay, we always say in medicine, replication, what does the totality of evidence say? BMJ published this paper from Denmark in 2020, and I said it in the older population, we showed no association. So what was the ideal LDL level for longevity, right? For everybody, from people aged 20 to 100, 100,000 people studied over 10 years, and they found the ideal LDL was basically between 3.4 and 3.9 millimoles, all right? Or 132 or 154 milligrams per deciliter, right? Now, why is that important? Across the world, if you get a blood test now and your LDL is above 3, you're going to get your GP calling you in saying you're at risk of a heart attack, we need to lower your cholesterol. But guess what? Higher level of LDL, the longer you live. Right? So again, it's consistent with even from the original Framingham study, it's consistent with what we found. They again replicated in another population. All right, what about FH? I'm here telling you, I don't think LDL cholesterol is a risk factor for heart disease. All right, but people go, well, hold on. Familial hyperlipidemia, these are the people that get heart disease in their 40s and 50s, people who have LDLs above 10, for example, right? Now, what's really interesting, and most people don't know this, is that with FH, they're not all the same. 70% of women with FH untreated will not develop premature heart disease, and 50% of men will not develop premature heart disease. So it's like, okay, so we decided to do another study and look at that group and see, were the people who got heart disease with FH having higher LDLs, much higher, say 15 or 20 versus 12, and was that the reason? We found no difference. First of all, the LDL level in people with FH who got heart disease and the people that didn't was exactly the same. All right, so it's not LDL. What was it? So Michael found this interesting as well. The Lp(a), which is a subfraction of the LDL, which is related to clotting and inflammation, was higher, and that was clearly associated with people with FH and getting heart disease. And also some clotting factors. But this is also interesting. So they also looked at what else would lower the risk in people with FH in developing heart disease, almost to completely a normal, healthy person, right? Low insulin, low waist circumference. So basically, when you've got patients who've got genetically high, and this is how I manage these patients, and we can do other tests like do calcium scores and look at their arteries as well. And I find a lot of them have completely normal arteries in their 50s and they've never been treated for high cholesterol and their LDL is massively high, is they're not insulin resistant. They've got normal waist circumference, they've got normal triglycerides and HDL, which is a marker of insulin resistance, their blood pressure is normal, they're not pre-diabetic. So that is really, and that again is the insulin resistance paradigm, right? So that is very interesting. So not all FH patients need to be, and a lot of doctors think, oh my God, you're about to drop dead. I've had people coming to me with FH and say, I don't want to go on a statin, but I'm really fit and healthy. I'm cycling, 5 miles a day and I've got a 6-pack and, I eat a healthy diet. Like, I don't think I need it. I said, listen, let's reassure you. Heart disease starts to develop in your teenage years. So this is the approach I have. If you're in your 50s and you're suddenly diagnosed for the first time with FH, you never had your cholesterol checked and it's through the roof, I say to these patients, listen, let's go a CT coronary angiogram on you. Let's look at the vessels. If for you cholesterol is a problem, you're going to have some heart disease already. It might be minor, it might be moderate, it might be severe. You're going to have heart disease. And I wrote about this. Several patients I did it on, consistent with the evidence, completely clean arteries. Leave them alone. You don't need to be on anything to lower your cholesterol.
How common is that FH, did you say again?
FH, 1 in 250 people.
Right, so not common.
Not that common. But the thing is, it also applies in the keto world. We have these, about 10% of people who go ketogenic diets, their LDL goes up, especially slim people, and they call it hyper-responders, okay? And there's been a study done recently, done by a guy called Nick Norwitz and Dave Feldman in America, you might know about it. In fact, you haven't seen the cholesterol code. Yeah. So they showed, for example, it was only 1 year study, but it showed there was no, and it's consistent, right? It's not just it's consistent with what, I remember meeting Dave Feldman before he did the study, mate. I said, listen, I can tell you your results already. I said, I tell you why, because in FH patients, right, who've got genetically high LDL, they don't get heart disease if they're not insulin resistant. These guys are not going to, they're a different group. And I predicted it, and it seems, it's proven right. So what else? Okay, one of the things we're taught and indoctrinated to believe is that the lower the LDL, right, the less likely you are to get heart attacks, right? So it's indoctrinated amongst doctors. It comes from a group of scientists at Oxford who I think have got a big bias because they've taken hundreds of millions from the drug industry. They've never shared the way they do their analysis, and they have dictated all the guidelines around the world. They published a paper in the Lancet in '96, I think, and they basically came out saying that there's a very clear linear relationship. As you lower your LDL by 1 millimole, you're 20% less likely to have a heart attack, have a stent, or need a bypass, right? So myself and 2 cardiologists thinking this is maybe a bit sus, let's just see if this is true. We did analysis of 35 randomized controlled trials, of drug industry trials, by the way, which have never been independently verified. So this is still best case scenario, what they're presenting us. We still looked at that data that they were presenting us to see, was it clear? And this is looking at statins, PCSK9 inhibitors, which are injectable cholesterol-lowering drugs, LDL-lowering drugs, and ezetimibe, which is another cholesterol-lowering drug. We found no clear correlation. So as far as I'm concerned with everything we know, and I tell this to my patients, I'm very open with them, I do not feel there is any benefit. I do not lower LDL cholesterol or proactively lower LDL cholesterol as a priority in any of my heart patients. Ones that are trying to prevent heart disease and the ones that have already got heart disease. I do not do that at all. All right, and I back that up with the evidence. Okay, so the benefit is, okay? And one is of people, the way that the doctors and maybe patients have been misled is just a misusing of statistics, something called relative risk reduction, all right? Let me explain it to you. It's very simple maths, okay? It's not complicated. So the way you can present a benefit as relative risk reduction or absolute risk reduction. If you present benefits as a relative risk reduction, as opposed to absolute risk reduction, it can exaggerate the benefit of a treatment. So for example, if you have a trial of, say, type 2 diabetics and you treat one group with atorvastatin, a cholesterol-lowering drug, 10 milligrams, and the other group with a dummy pill, over 4 years, there's the results of the trial shows 48% less likely to have a stroke. Sounds pretty dramatic, right? Wow. So take the statin every day for 4 years, patient comes in, you're almost 50% less likely to have a stroke. Oh my God, doctor, I'm gonna take this, right? What does that actually mean though, right? What happened in the trial is, you had 1,000 people who didn't take the pill, okay, were followed up in one group. Out of those 1,000 over 4 years, 28 of them had a stroke, okay? In the group that took the pill, right, took the statin, 1,000 people took the statin, 15 of them had a stroke. So you've reduced from 28 to 13 out of 1,000, right? So 13 over 28 times 100 is 48% less likely. Wow. It's a relative risk reduction. Yeah. But the absolute risk reduction is you needed to treat basically if you treated 1,000 people, 13 would benefit, which is 1.3%. So for an individual, that is 1 in 77. So the way you should be telling patients, and what I do, if you look at this trial and you trust the results, right, because it's still probably a biased trial, right, is that there's a 1 in 77 chance that if you take this pill religiously.
And one more point is that it's a single outcome we're measuring here. We're not measuring all other outcomes.
Absolutely. Absolutely right. And again, the trials were designed to take people out who had side effects. So so what I always say, if you don't get side effects, you trust the drug industry completely and data that's not independently verified, and you take this every day, 1 in 7. This is what I tell my patients. I put it in my letters. right? I put it in my letters back to the GP, who don't know all this stuff, but the patients are happy, they're fully informed. They feel like, okay, some patients say, I want to take the chance. I've got a strong family history, I'll take it, fine. Other patients say no. Individual patient preferences and values, right? Give the patient the honest information, let them make a decision. Some patients say, I'm not sure, doc, and they still wanted the doctor to decide, and then fine, I'll say, listen, I don't think this is beneficial for you. And by the way, this is without even talking about the alternative, about the lifestyle, about low carb or diet or whatever else. We haven't even gone there yet. This is just without even talking about other options, okay? I'll just fast forward because we don't...
Do you get in a lot of trouble for saying that at the time?
What do you mean for...
Not recommending statins?
No, because it's informed consent. I've not had any... Listen, I'm not a single patient... Listen, touch wood. Touch wood. I've not had a single patient complaint in my entire career,
which is... Not the patients, but big pharma on you.
Oh, of course they're not happy about it because, I get misrepresented. So I in 2019... there was a massive hatchet job on me and two other scientists in the Mail on Sunday, front page, where I'm all about informed consent. They misrepresented, said I'm a statin denier, right? And they called me, and there was an editorial by the health editor of the, and it went to court, and I wasn't involved in the case because I couldn't be bothered suing them. I had to still talk about statins. I had to keep quiet, otherwise the other two people won the case, so it's a moral victory. But he basically said, you're going to laugh. Please feel free to laugh because it's so ridiculous, right? The editorial from the health editor with a picture of me and two other scientists, a place belongs in hell for the doctors that say statins don't work.
Wow.
Yeah, and I lost my NHS job after that. They didn't say it was because of that, but suddenly I got notice 1 month, you got to go. And then anyway, that's another story.
You wrote the book.
Yeah, I mean, I've been writing lots of books. But listen, don't just take my word for it now, okay? World Health Organization 2009 said it's an ethical imperative that every patient and doctor understand the difference between relative risks and absolute risk reduction to protect unnecessary anxiety and manipulation, all right? Now, I got this published in I got the Medical Royal Colleges in 2015. I wasn't just doing this on my own. I engaged with the organization that basically guides and advises every doctor in the UK. I was lead author. I had the chair of the GMC, General Medical Council, as a co-author. I sat around with all the Royal College presidents. I said, this is a campaign. BMJ have said there's too much medicine. This is one way we can combat this, is to get more informed consent, lifestyle. You can look it up. It's called Choosing Wisely, 2015. Got all over the news and whatever else. And that's before I was the main guy. I was the face of it. And they basically tried to take me out. Medical Royal Colleges, something happened. It's in my documentary, First Doing a Farm. The new chair took over, got some pressure from Royal College of Physicians, I think, and they suddenly wrote me an email. I'd worked for them for several years. Aseem Malhotra, basically, in polite terms, we want to disassociate, because there was a story about statins, about a guy who was keto, who had a heart attack, stopped his pills. We wrote it in a medical journal, got into the news, and the Daily Mail did a front page saying, ditch the pills to beat heart disease. And that caught, of course, that's for big pharma, that's terrible. Who's the instigator? Aseem Malhotra. That's probably what happened, right? Oh yeah, there's probably a movie here at some point, but I've got so many other things to do.
That's why you don't get complaints, did I?
What's that?
That's why you don't get patient complaints, is it?
What? Because what?
Because they die.
Because they don't live.
Oh yeah, exactly. Because they don't live. Yeah, absolutely. Well, actually, that could be the case. But I actually got I got an award a few months ago for the highest patient rating in London. But if that wasn't the case, then maybe that was true. Yeah. So anyway, so this is what we wrote about, Choosing Wisely in the UK, and I was first author on this, and you can look it up again. And this was like a campaign from the medical organisations to reduce over-medication in the population. But the pandemic happened, and the campaign has suddenly stopped.
Yeah.
Right? So imagine, and I was taken out, and no one else is there to lead it, unfortunately. Okay, fine. So I'll just carry on a bit further forward. So let's just look at statins, okay, just to break down again for individuals, because this is helpful, right? So if you have a low risk of heart attack or stroke, which is most people prescribe statins around the world, and that's up to 1 billion people prescribe it, and they're not told this, from drug industry-sponsored trials, there's a 1 in 100 benefit it'll prevent a heart attack or stroke over 5 years without prolonging your life. The reason I say 5 years is that's only as long as the trials last. Now, some people argue the benefits would accumulate with time, but I could also argue the side effects accumulate with time as well. But at least over a 5-year period, there is no benefit in terms of lifespan. If you've had a heart attack, there is a better benefit, 1 in 39 in preventing a heart attack or a stroke, and 1 in 83 for saving your life or delaying your death, okay? If you're over 75, this is what I said in the US Senate last week. I said President Trump We have public available information on President Trump knowing that he's not got any significant vascular disease, he's had coronary calcium scores, he's not got any severe blockages, he's not high risk, he's over 75. I said President Trump probably doesn't know that his benefit of a statin over 5 years is 1 in 446, right? So no one is immune to medical misinformation, not even the president. All right, this is a system culture problem. Yeah, he's on a statin. He's on a statin and a cholesterol. And it's publicly available information. I'm not breaching confidentiality. The doctor put it out. And I'm like, he's on that, and he's also on aspirin. And if you have a calcium score less than 400, calcium score measures, plaque in the arteries, right? If you've got a calcium score less than 400, we know from a few years ago it was 130. I don't think it's above 400 because it'll be more significant disease and they'd mention it. You're more likely to suffer a fatal bleed from taking aspirin than it preventing you having a heart attack. So aspirin is also massively overprescribed. And patients, and there's again just a mindset to prescribe and not think about the other harms. And that's clear totality of evidence data on that. So what about have statins reduced? People say, statins have saved millions of lives and blah, blah. Have they reduced mortality according to observational population data in the population? Study looking at European countries over 10 years. Despite millions more people taking statins, there was no reduction in cardiovascular mortality in the population. Now, we've told you the numbers are small, 1 in 100, whatever, but there's another way of looking at the statistics. How much longer will you live if you take a statin religiously on drug industry-sponsored trials? Even in the highest risk groups, people have a heart attack, and these are selected groups of people in the trials, the median increase in life expectancy over 5 years is?
1 day.
Just over 4 days.
Wow.
Okay?
And that's for the ones with serious...
Yeah. Right? So that can explain why you don't see it. Because the other reason is up to 50% of patients prescribed statins within a couple of years stop taking them because they feel miserable on them. So that's how you can see in the population, it's not translating into a benefit.
I told you when my mum was 50, she was diagnosed with high cholesterol.
Right.
Gave a statin, 2 days later, couldn't walk. I had to walk backwards like a crab. And then my dad threw them away. 2 days later, she was back to normal. She turns 80 in July, never took anything.
Amazing.
Since.
No, I hear these stories all the time. And what the people who are pushing the drug narrative will say, and they'll do studies to tell you that these patients are imagining the side effects, and they'll do these studies and say that it was imagined, it wasn't real. No, I'm serious.
Really?
Yeah. So what the problem of this whole LDL focus is, you've got millions of people prescribed statins who are at low risk of heart disease. We do also know statins do cause, this has been shown now and accepted, they cause type 2 diabetes in between 1 in 100 and 150 people. Albeit reversible, but still, you don't want to be getting type 2 diabetes because of statin. So you keep, and then the whole low-fat movement, because the fear of cholesterol has been so strong, it applies to the food industry, low-fat food, lower your cholesterol. Yeah. People have naturally then increased their refined carbohydrates and sugar. You've got an explosion of obesity, type 2 diabetes, and you've not curbed heart disease. Right? And then you get this issue. You have something called statin gluttony as well, which is people have the illusion of protection. I have patients coming in who think they can eat what they like because their cholesterol's low, and you've got this. Right. And this is a real thing. It's a real phenomenon. It's the illusion of protection. Right? Okay, so I wrote this article in the BMJ. I wrote several articles with 2 cardiologists, and this is, in my view, looking at all of it, and this was well publicized. It broke the record in the journal, 1 million downloads, went all over world news. And I said, saturated fat doesn't cause heart disease. Heart disease is a chronic inflammatory condition. The risk can be effectively reduced from healthy lifestyle interventions. It's not rocket science. So what is it? I created this picture. Okay, you've got your heart disease, you've got your the plaque and potentially rupturing, causing heart attacks. You've got the fireman putting it out. So what puts it out? Okay. Now listen, there are different diets. I'm not saying that my diet is the best diet, but on the evidence that's available that we have in nutrition science, which is not amazing. Okay. I think that the ideal diet for heart disease is an anti-inflammatory low-carb diet. And what does that mean? It means a low-carb Mediterranean diet. It means, extra virgin olive oil, good quality extra virgin olive oil, nuts and seeds, oily fish, omega-3, moderate intake of cheese and yogurt, fine, low in sugar and refined carbs, walking, okay? Exercise is great, right? Too much exercise, by the way, is bad. You have this curve where, at higher levels of exercise, you get, I see people who get heart disease because they're overtrained, they under recover, all right? But a little bit goes a long way. You look at all these blue zones, people around the world that have high longevity, these people weren't pounding it in the gym. They were just outside, they were farmers, they were walking, they were getting vitamin D, So just being active, not being sedentary, is when it comes to lifespan for me is, and of course injuries. I see a lot of athletes, right? A lot of people that have been, I won't name them, some very famous athletes, and they're crippled now. These are some Olympic, like, they're walking around this, they've screwed their knees up from running on the flat surface, you know. So it's about training smart, right? That's what it's about, okay? And then the last but not least, I think the one that is going to get a lot more attention is, again, stress reduction, okay? And you know, through things like breath work, meditation, yoga, chronic stress. And most of us are probably at that level because of what's going on in the world at the moment. Chronic stress now in terms of heart disease risk is the same as smoking 20 cigarettes a day. Because what happens is, and this is evolutionary, it's very interesting, right? So if you go back a million years and you're in the jungle and you're running away from a saber-toothed tiger, right? The acute stress response, what happens is your body releases inflammatory markers, factors and clotting factors. So it reduces your risk of bleeding to death if you're attacked. What we've got now is chronic low-grade stress. So we've got this little thing going on, and heart disease is an inflammatory condition related to clotting, and that's how you turn it off by some profound deep meditation, changing your way you think, less anger, and that's actually been shown, I'll come on to it in a minute, it's been shown to potentially reverse heart disease. Now, the good news of all of this, I'll just fast forward because we haven't got that much time, but the good news about all of this is that the dietary changes, and I've written 3 books on all this. A lot of people come into it and they think, bloody hell, you know, I've lived a certain life, I've had sugar, I've got a bit of a belly, what's the point, you know, I'm not going to enjoy this. It's rapid. It's rapid in terms of the risk factors. You can, you know, I've seen people who've got their type 2 diabetes into remission. They've had it for 15 years. Within 1 month, they followed a low-carb Mediterranean diet, what I've advised them, their glucose is normalized in a month, okay? Triglycerides, take people getting off their blood pressure pills. You combat insulin resistance. Yeah, and the thing is, there's 2 things. One is they get their markers better, which is motivating, but a lot of them feel better. It's like, bloody hell, that brain fog and walking around and, you know, a bit of joint pain, suddenly like, bloody hell, you know? You see it with keto. So that's the other thing. And Tony Royal was a patient that came to me many years ago. He was an airline pilot with Virgin in his early 50s, running marathons, low-fat diet, thought he was doing the healthy thing, had a bit of a belly, gaining a bit of weight, had a heart attack. Luckily not when he was flying. Had a stent put in, didn't have significant heart muscle damage, the ejection fraction was still normal. Put on all these pills, got miserable, thought he was having side effects. He couldn't fly anymore, so he went back to being a maths and physics teacher. Very good with data. Started reading the papers of all the drugs he's on. He's like, oh, the benefit's 1 in 100. What's this? Thinks he's having side effects. Stopped the statin because he was getting erectile dysfunction, feeling miserable, going on for months. He found my work. He looked up online and saw the stuff. Went low carb. Within 3 months, all his metabolic markers got better. He came to see me doing all this himself. He stopped all his pills himself, which I wouldn't recommend, by the way, but he did it himself. And he said, listen, I am breaking my own records in ultramarathons. Wow. And I want to ask you today, Doc, when he first saw me, and I was shocked, he came into my office in private clinic in 2015. He goes, I want to ask you whether I can do Ironman. So this guy's had a heart attack and stent, stopped all his pills, and he's coming and asking me whether he can do Ironman. And now, you know, so this is what led to that whole, you know, I wrote about him in a medical journal, Daily Mail, Daily Express, front page, ditch pills to beat heart disease. I talked to the journal. I like to provoke, you know, stir the pot a bit, and they, you know, I know how to get stories out there. And it was like, and eat your way to about experts. And this is him now. I mean, he's doing really well. It's 2019, but now he's still, all his metabolic markers are great. And he's actually better and faster than he's ever been. Wow. And he's 60 now. Wow. Right? And he's keto. He's obsessive keto. Look it up, Tony Royal, Royale. You can look at the articles written about him, stuff like that. He's amazing. Right, so just to end, I said this yesterday in an event that was in Marbella with his hedge funders that were doing a tennis tournament, is that Christian Barnard, who is the pioneering heart transplant surgeon, said, I've saved 150 lives with heart transplants. I would have saved 150 million if I'd focused on preventive medicine. Preventive medicine actually is a lifestyle medicine. Right, thank you. Right, we've got about probably, hold on, maybe about 10 minutes for questions. And
you see, guys, this is what I said with my my client. He couldn't get out of bed. He's been on heart blood pressure medication for 25 years. My age, 5 days, his blood pressure came to 128/80.
Right.
His morning blood sugar was 228, fasted. Within 2 weeks, it's now 140. He's got 0.4 ketones. He texted me and said, I can't believe it. I'm outside digging the garden for 8 hours a day. Before, he couldn't go outside. He was exhausted and in agony. He was on tramadol.
Right.
He got rid of all medication himself, not with the blood pressure medication, but his painkillers.
Yeah.
And he said, dare I say, I've got zero pain. and it's given his life back. So, why can't the doctors do that?
Oh, it's saying 2 minutes. They said 2 minutes. We'll make him wait a bit longer. It's fine. All right, guys, fire away. Any questions?
I have a friend with FH. I think he was in his lower 50s or something, playing badminton, really healthy. And then the doctor, he has FH, I think.
Yeah.
When I talked to him last time, he didn't listen to me, and he went on PCSK9 inhibitors. And now he looks like 90 with stripy white hair and can't play because he's so inflamed. Have you seen anything similar to this?
I mean, yeah, it's difficult to know, right? I proactively don't lower LDL in patients. I mean, rarely, sometimes I will, but I think I've had patients who've suffered side effects from these injections, and they felt better when they come off it. So I suspect that's probably causing a side effect. If he feels that things have changed since then, he'd probably be better off it. But if you want to recommend that he see me, I can do a virtual consultation with him and figure it out.
It's probably not reachable, yeah.
Okay.
Because he's taken over by...
He's indoctrinated, yeah.
The almost new kid on the block these days on the tube is ApoB.
Yeah.
I think it's like they're scaring us with that one.
Yeah.
What is that?
Yeah, it's just another part of the cholesterol profile. But basically, the bottom line is this. If your triglycerides and HDL are normal, you can forget about ApoB, you can forget about LDL cholesterol.
Good.
So metabolically healthy, forget about these biomarkers.
My other client, his HDL his triglycerides has come down 30% to 80
Yeah.
in America.
Yeah.
His HDL is a bit low still, at 38.
You can push up a saturated fat.
Yeah. Push up the saturated.
Yes. So saturated fat, cheese, steak will raise your HDL. Olive oil can also improve the function of
He
HDL
said
too.
now he's going to quit the steak and eat chicken breasts. He said on his post, this fella, I can't eat steak anymore because I'm going to have a heart.
I know, mate, but most people are still... And the thing is, because Big Pharma was so successful in pushing a narrative that the COVID vaccine saved millions and millions of lives, and I predicted this. I knew this was going to happen. I predicted it. I said it to people. I was publicly about it. I said, just watch what's going to happen now. The cholesterol thing is going to re-emerge, and we're going to get more people getting, pushed and feared into taking cholesterol-lowering drugs.
Yeah. So saturated fat will raise his HDL.
Yeah. Yeah, and saturated fat doesn't cause heart disease, so I wouldn't worry about it.
I don't worry about it.
Anti-vaxxer, loads of eggs.
Yeah. One last question.
Can you tell something about your political engagement in the US Senate and all of this? Just brief.
Yeah, I was there last week. I was invited by Ron Johnson to discuss the relationship between COVID vaccine and cancer, but also suppression of scientific discussion. And I got it into there, and you can. I've showed the video. Please share the video with them as well. But
shocking.
yeah, and this is an important committee because this is the same investigations committee that investigated Enron, the opioid crisis, big tobacco. Yeah, it's the same guys, the same committee. So we're this is the real deal. So. Yeah. So we'll see what happens. We got to keep talking about it. But guys, listen, all of you have a role to play. A lot of people think, hold on, what can I do? No, listen, every conversation you have with your friends, your family, just think, how do I get to at least think a bit different? There's different, of course it's not easy to have difficult conversations with people, but it's a ripple effect. This is going to change at the grassroots. So all of us, we have more power than we realize. Honestly. But we become a bit apathetic and we're like, yeah, someone else is going to sort it out. No, we have to sort it out, guys. If we're not part of the solution, there's no solution. Right? So just do whatever you can in a compassionate way, get people thinking. If you want to send them to my videos and maybe they get convinced by me or whatever else, do that. But just get the conversation going because otherwise we are completely screwed. We're going to be completely screwed. We already are a bit, but we're going to be even more screwed.
Just quick question. For people that took the COVID vaccine, is that going to be a permanent DNA damage? Or is there...
I don't think so, mate. But the thing is, one of the reasons we're having this discussion, we need more investigation because there are people having cancers that we think is COVID vaccine related. Yeah. I know there are people having heart disease and heart attacks because of the COVID vaccine. So we need a full, okay, there's a problem, guys. Let's try and find out who is at risk and what can we do about it. I don't think everybody's at risk, but I think a lot of people are. But we don't know, we do I do stuff with my patients and look at some things I think, but we need all the best scientific minds in the world to concentrate on it so we get solutions.
So there's no way to really know if you can detox?
No, listen, I don't think. There's augmented NAC. You can get a test for spike protein in Germany, look that up. But actually one of the things I found, that more likely to get complications of vaccine injury if you're metabolically unhealthy. So again, it comes back to optimizing yourself, low carb, keto, metabolic health, stress reduction, good sleep, all that stuff. Yeah? Because the people who are more vulnerable to vaccine injury were the people who are also more vulnerable to COVID, and that was related to excess body fat.